Good, I think we're live. Hello, everybody. Welcome to Instructional Course 018, Contemporary Pharmacotherapy for OAB 2024, Monotherapy and Combined Pharmacotherapy to Optimize Treatment. So I want to introduce my esteemed faculty, Dr. Alan J. Ween, Professor of Urology now at the University of Miami, and Ariana Smith, Professor of Urology at the University of Pennsylvania. My name's Eric Rovner. I'm Professor of Urology at the Medical University of South Carolina. So, I have to read this as a CME. The AUA policy states that all planners, authors, and presenters must disclose to the AUA prior to their presentation all relevant financial relationships with any ACCE-defined ineligible company, formerly known as commercial interest. The AUA determines if the relationships are relevant to the educational content and mitigates any conflicts of interest prior to the educational activity. Disclosures or relevant financial relationships are posted on the AUA's annual meeting website, and a link is posted in the mobile app. Please remember to silence your cell phones. No photos, video, or audio recordings are permitted. Courses are selected based on evaluation results, so please complete the course evaluation. When you do, your name will be entered into a drawing for complimentary registration to AUA 2025 in Las Vegas. You can evaluate this session by selecting Evaluate through the credit claim process. You go to AUA 2024 mobile app, click on the CME button, or go online and click on the CME page. All right. So we're going to have some ARS questions to start. In order for you to access the ARS questions, please scan this QR code if you didn't get it scanned in when you first came in. So I'll give you a few seconds to scan that, because of course I didn't do it. Okay, so hopefully everybody's scanned in, and we are going to start. Okay, first question. As a class, beta-3 agonists as a class are more effective than antimuscarinics. B, prevent dry mouth via the same mechanism as pilocarpine. C, exert their favorable effects at least in part by a similar mechanism of action as norepinephrine. Or D, are associated with bradycardia and hypotension in the elderly. So I think you have 15 seconds. Oh, there it is. Okay. Okay. Next question. As compared to monotherapy with solifenacin 5 milligrams, combination therapy with solifenacin 5 milligrams and mirabegron 50 milligrams is associated with A, a lower incidence of dry mouth or xerostomia, B, greater reduction in urinary urgency episodes, C, a higher risk of symptomatic bradycardia, or D, less risk of urinary retention. And you can now answer. I hope the questions are getting easier. All right, polling question 3. According to the updated 2024 AUA OAB guideline, which you haven't seen yet since it's going to be presented at this meeting, partially presented at this particular course, urodynamic evaluation A should be performed prior to the initiation of oral antimuscarinics in the elderly. B is indicated prior to onabotulinum toxin A in patients who have failed both behavioral therapy and pelvic floor exercises. C, using fluoroscopy is indicated in the initial evaluation of a 62-year-old female with urinary urgency following a CVA. Or D, can be performed in patients with mixed urinary incontinence refractory to beta-3 agonists. So go ahead and answer. Okay. Question 4. The risk of hyponatremia with the use of DDAVP is A, increased with fluid restriction in the evening, B, mitigated by concomitant use of oral alpha blockers, C, less likely to occur in the elderly, or D, greater in patients with low baseline serum sodium. So go ahead and answer. Question 5. Current gene therapy trials for overactive bladder with Euro 902 A, exert their favorable effects on OAB via reduced acetylcholine release from presynaptic parasympathetic neurons. B, utilize a naked DNA vector for a portion of the MAXI-K channel. C, have demonstrated superiority to antimuscarinics in reducing UUI episodes, or urgency urinary incontinence episodes. Or D, have shown higher rates of urinary retention as compared to beta-3 agonists. So go ahead and answer. Okay, and we're going to hear about gene therapy from Dr. Wien. Okay. That's all of the ARS questions. Unfortunately, I can't give you the answers. What's going to happen is you're going to get a note from the AUA in a few weeks to answer those questions again as part of the course evaluation. So thank you in advance for doing that. All right. Good. I introduced our course faculty again, Eric Rovner, Alan Wayne, and Ariana Smith. This is our agenda. We're going to cover some aspects of patient expectations and goals with overactive bladder therapy. We're going to cover the AUA guidelines, the new AUA guidelines, at least a portion of the guidelines that pertain to pharmacotherapy. Talk about the physiologic and pharmacologic principles underlying overactive bladder as a condition, and then discuss monotherapy and then combination therapy for overactive bladder. We'll talk about nocturia, not necessarily always related to OAB, but certainly a condition that our patients see all the time, and then future directions in OAB pharmacotherapy. So that's the objectives, that's the agenda. Let's see, is this going to work? No, neither of these are working. All right, so we'll advance that way. Okay, those are the learning objectives. All right, so first we'll talk about patient goals and expectations in OAB pharmacotherapy. Those are my disclosures. So first, a definition of OAB, that's what we'll be talking about today. That's urinary urgency, incontinence frequency, and nocturia. You're all familiar with that. Again, to emphasize, not related to another condition in the urinary tract. So if you have urinary tract infection, if you have a bladder cancer that results in urgency frequency, that's not overactive bladder, because presumably if you treat that primary condition, your symptoms would improve. So it's in the absence of other pathology. So what are the goals of OAB therapy? We're going to be talking a lot about treatment of overactive bladder, a lot of combination therapy, individual therapy, behavioral therapy. What are the goals? And it really depends on the perspective, right? The goals of the physician are a little bit different. The goals of regulatory agencies that determine whether or not drugs will be approved. Certainly industry's perspective is very different from physicians and patients. And then finally, what are the patient's expectations and goals in overactive bladder therapy, which are not necessarily related to the top three, but in fact are probably more important than the other three. And the way we look at overactive bladder outcomes or therapy is these measurements here. So we can look at diaries, urgency incontinence episodes, frequency, urgency. We can look at patient-reported outcomes, including using questionnaires. But is that what the patient wants? Is that what the patient expects? And this is the bastardization of a quote from Willett Whitmore, a prostate cancer guru from years ago, who, regarding prostate cancer, says, is cure necessary in those for whom it's possible, and is cure possible in those for whom it is necessary? And we could say the same for overactive bladder, although certainly not a life-threatening condition. The term cure, at least from the patient's perspective, and somewhat from the physician's perspective, actually is the same. What does the patient want or expect, and is it realistic? Is it achievable? And is it necessary? And if it's not, what should we do? So if the patient doesn't reach their goals, if they're not cured, and I will offer shortly that cure is perhaps not their goal, what should we do? Should we provide realistic goals? Should we downplay or sandbag patients' goals? Or should we just continually provide more aggressive therapy until the patient's cured? Well, I'm going to start off with OAB is complex. Ariane, Dr. Smith is going to talk much more about this. We don't really understand what causes overactive bladder, and maybe it's a combination of this laundry list here. Maybe in some patients it's one of these factors, and maybe in other patients it's 2 or 3 of these factors. But for sure it's not all of these factors in all of the patients. And whether you're a lumper or a splitter, you would say that all of these are contributing factors in some patients, or 1 or 2 of them are contributing factors in all patients. And this is just a cartoon of sort of the neurogenic, myogenic theory, afferent versus efferent pathways contributing to overactive bladder, and Ariane is going to go into that in much more detail. What is the natural history of OAB? What if we do nothing? Well, remember, the urinary tract is not like cheese and fine wine. It does not get better with age, right? It either gets worse or it stays the same. Most of the time it kind of gets worse. And we know, looking at longitudinal studies of bladder anatomy and physiology, that detrusor overactivity increases. We know that detrusor underactivity increases, and we know that all the comorbidities that lead to urinary dysfunction outside of the bladder also increase. So as we age, there's all these other comorbidities that are external to the bladder that also cause urinary dysfunction that are not going to be at all treated by any of the things that we're going to talk about. So although the bladder is the organ that we're going to talk about today, there are all these external factors that contribute to urgency, frequency, nocturia that are completely unrelated to the bladder. So despite these complexities, what does the patient expect? Back to the patient. Is this what the patient expects after 1 week of overactive bladder therapy? Take drugs for a week and I'm done? I don't think so, and if they think that, it's because we didn't, as physicians, do a very good job of counseling them that the therapy we're going to initiate is a therapy they're going to need for the rest of their life, by and large, unless they went to a different type of non-pharmacologic therapy. So do patients expect resolution of urgency, frequency, nocturia, and incontinence? No adverse effects, and the drug being inexpensive and improved quality of life, or not? Of course, some patients might think that way, but I would offer that many don't. What is a perfect overactive bladder result? And I want you to think about how many patients wind up like this no matter what intervention you do for overactive bladder. Are they dry? Do they have no voiding symptoms, no new voiding symptoms, low cost, and no adverse effects? And I would offer that almost nothing we do for overactive bladder is perfect. And I can't explain exactly why, but I suspect it has something to do back to the pathophysiology of overactive bladder, that it's not one uniform disease. The realities of OAB drug therapy, all the things we're going to be talking about, whatever drug we talk about, and here's the list in no particular order, is that there is a low cure rate. It's a modest decrease in urgency frequency, a modest decrease in urgency incontinence with adverse events, despite some drugs claiming no adverse events, and with a variable cost. To give you some idea of patient expectations and how the way we measure them is a little bit different from the patient's perspective, and our expectations are a little bit different than the patient's expectations, we can look at the ABC trial. The ABC trial was an NIH-sponsored trial a number of years ago, looking at Botox versus a variety of different antimuscarinics. And basically it was 241 patients randomized. The specifics of the study are not particularly important, but they were randomized to drug or Botox, and the primary outcome was urgent incontinence episodes at 6 months. The important thing is primary outcome, 6 months, urgency incontinence episodes. So if you look at dry rates from the ABC trial, again, NIH-sponsored trial, pretty good trial done by some pretty smart people, the dry rates here I've circled in red. drug dry rates, that is, complete resolution of any incontinence or urgency incontinence, was 11 to 13%, pretty miserable for drug. And for Botox, the dry rates were 23 to 27%, depending on whether you're looking at just urgency incontinence or all incontinence. So pretty terrible dry rates, right? We would all agree. But if you ask the patient, were they much better or very much better, more than half in each group were better, despite the fact they weren't cured. So that gives you a hint that patients aren't actually looking for cure often, and getting them a little better, much better, or a lot better is probably what they're looking for. Physician and patient goals are often not aligned. We know that. There's lots of literature on that. Patient goal achievement, that is, whether patients are happy or not, shows no significant correlation with objective measures, diaries, etc. So what then is the patient asking for when we treat them? Is it a self-determined goal? And I point you to some work by Linda Brubaker, a urogynecologist, a number of years ago. And she developed a questionnaire called the Self-Assessment Goal Achievement Questionnaire. The details of the questionnaire are not important. It's the concept. The concept is you ask the patient what they want, what they're looking for, and then you try to achieve that goal. Some patients want to reduce their frequency. That might put you in a different therapeutic paradigm than somebody who wants to reduce urgency incontinence episodes, different from a patient who really is bothered by their nocturia but doesn't care about their daytime symptoms. So looking at the symptom that bothers the patient the most, and Dr. Brubaker looked at this sort of questionnaire in a lot of different conditions, pelvic organ prolapse, stress incontinence, interstitial cystitis, and it actually turns out to be a pretty good measurement of what patients want. We actually use this in the neurogenic detrusor overactivity trials for Botox, the phase 2 Botox trials. What we asked, this was a study from, now it's 9 years ago, it was a phase 2 for neurogenic detrusor overactivity for Botox. And basically we took patients, we said these are all neurogenic patients, and they could present with a number of different symptoms. They're all listed here under the red circle, being dry, reduce incontinence, a variety of others. And we asked them, which is the one you want, and then they all chose. The important point here, and this is looking at, the black is the each of the goals for Botox, and the white rectangles are all of the goal achievement for placebo. But what you see is an incredible difference between active therapy and placebo. A huge difference, much bigger than you're going to see for any other drug in any of the objective outcome measures that you're going to see for the next 2 hours. But here, the placebo response quite small, and the intervention response, the Botox response, much bigger. Big difference. So if the patient actually chooses, you actually get a big response. So in summary, OAB is complex. Traditional measures of OAB may not capture important data, and communication is the key. Ask your patient what they want, and you might be able to achieve a reasonable goal. I'm going to move on now for the next few minutes and talk about the OAB guideline, the new OAB guideline. I'm going to go through it pretty quick. First, I want to say that this guideline is completely different from the previous guidelines. This has been an evolution. Starting in 2012 was the first OAB guideline, then 2014 it was updated, then 2019 it was updated, and now in 2024 there's an all-new guideline. The process was very different. Although we incorporated many of the prior statements, there's lots of new statements. I want to thank Ariana Smith, who's sitting at the table here, who was one of the lead authors and organizers, who corralled, amongst others, myself, a bunch of cats in a room, to get this guideline done. She and Ann Cameron did an outstanding job. This is not a revision of the prior guidelines. This is a brand new guideline looking at the literature of the last 10 years. There's 35 statements. I'm not going to go over all the statements, but there are many new concepts that were addressed in this set of guidelines, including male OAB, telemedicine, a variety of looking at comorbidities, and recommendations specifically, which you're going to hear about today, about antimuscarinics and cognitive changes. I'm not going to go into how the AUA goes into how they come up with these guidelines, not particularly important. There were 35 statements that, as best as we could, we tried to base them on the available literature. We had 3 strong recommendations, 3 moderate recommendations, no conditional recommendations, 17 clinical principles, and 12 expert opinions. The point there is that maybe the evidence is not as great as we would like it to be for certain statements, meaning that lots of expert opinion and clinical principles made up this guideline. One of the interesting things about the guideline is we decided to categorize interventions for overactive bladder. What you see here is the list of the way we've categorized the interventions, the treatment options, general management, behavioral therapy, optimization of other comorbid conditions, non-invasive therapy, pharmacologic therapy, minimally invasive therapy, and then maximally invasive therapy such as catheters and urinary diversion. So I'm not going to go into each of those. One of the new things we incorporated was nutraceuticals. Your patients come to see you and they say, I take whatever over-the-counter or $300 drug that they ordered from some company over the internet, and they say, Doc, should I take this? And it turns out that when you look at the literature, that the nutraceuticals actually don't do anything for overactive bladder. Now you can actually say that. It's part of our guideline. Vitamins, nutraceuticals, herbals really have never been shown to have any positive effect in overactive bladder in a randomized controlled trial. Similar to the prior guidelines, we can offer beta-3 agonists or antimuscarinics, and we should counsel overactive bladder on all the side effects of antimuscarinics. I'm going to go through these very quickly. You should assess patients who have initiated pharmacotherapy for efficacy. If it doesn't work, you should use a different medication in the same class or add a medication. You can use combination therapy, which is what you're going to see here. Caution was in the new guideline regarding dementia, cognitive dysfunction. I'm not going to go into that, but it's clearly in the guidelines now that antimuscarinics do have an effect on cognitive function, possibly irreversibly, and this is now in the guideline and it's very clear. So your patients who want beta-3s as opposed to antimuscarinics have a good case now. You can combine drugs. You can combine drugs with virtually any of the other interventions that we have for overactive bladder, including refractory overactive bladder. There's no longer a need to fail behavioral therapy to go to drug therapy and then fail drug therapy to go to invasive therapy. Using a process of shared decision-making, patients can choose to go directly to more invasive therapy if they should so desire. But again, that's under the conditions of shared decision-making. You can discontinue oral medications in patients who've had a response to a minimally or maximally invasive therapy. There's some discussion on OAB and BPH in males. I'm not going to go into that. Urodynamics can be used in patients when there's some diagnostic uncertainty, so statements there. And then finally, a statement on telemedicine. You can evaluate your overactive bladder patients using telemedicine initially, with the understanding, of course, that they're not there for a physical examination and a urine analysis, and at some point they need to come in for that. But then you can follow your overactive bladder patients using telemedicine. All right, so I'm going to stop there. That's our lovely bridge in Charleston. For those of you who haven't been there, I'm going to introduce Ariana Smith to start the next presentation. Ariana, let's see. Gotta go back. Should be here. No, we never got it. There we go. Okay. And this has to be on the arrow. This is not working.
This has to be on the arrow. This is not working. Okay, awesome. Good afternoon, everyone. You're probably first wondering how I got to be on a panel with these guys. Well, one fun fact, the 3 of us were together at Penn from 2002 to 2004, and they were 2 of my biggest mentors in life. They have now both moved on to greener pastures and sunshine, and yeah, I just stayed put carrying the Penn flag. I have no relevant financial disclosures. You probably wonder how that could be either, but that is true. All right, so today I'm going to talk about the physiologic and pharmacologic principles of overactive bladder. First, we'll quickly remind ourselves the definition of overactive bladder, and then we'll really get into the definition of urgency. We'll explore prevalence and impact, get into urgency physiology, and pathophysiologic mechanisms, and end with the pharmacologic principles. So my goal, I'm going to try to clarify some of the complexities underlying overactive bladder, including the multiple potential mechanisms responsible for the condition, as Dr. Rovner laid out briefly, and then the multiple therapeutic targets that Dr. Wien will go into with the treatments. So let's start by quickly revisiting definition of OAB. In 2009, the ICS and the International Urogynecologic Association revised the definition. OAB is a symptom syndrome. It includes urinary urgency, sometimes with frequency and nocturia, sometimes with urinary urgency incontinence, but it should be in the absence of UTI or other pathology that could explain the symptoms. In practice, we use the term overactive bladder in several scenarios that can be categorized as neurogenic overactive bladder, non-neurogenic overactive bladder with symptoms due to an identifiable cause, potentially reversible, like a urinary tract infection, bladder stone, bladder cancer, and idiopathic overactive bladder where there is no identifiable cause. Multifactorial OAB may in fact be a better term to describe idiopathic overactive bladder, since there are several pathophysiologic mechanisms that have been implicated and that often coexist in a single individual. In reality, though, the boundaries between all of these may not always be discrete. So to give a diagnosis to your patient of overactive bladder, you have to exclude underlying pathology that could explain their symptoms. You need to rule out UTI, bladder cancer, CIS, stones. And so how do you do all this? Well, you do this at the time of your initial evaluation through a comprehensive medical history, through a bladder symptom assessment, a physical exam, and a urinalysis. And that would be AUA guideline consistent. The prevalence of OAB in the US population is high. 16.6% of Americans are experiencing overactive bladder symptoms, which equates to about 33.3 million individuals. 37% of those are experiencing overactive bladder symptoms with incontinence, classifying them as overactive bladder wet, and 2/3 do not have incontinence and are therefore classified as overactive bladder dry. What you can see on this slide is that the prevalence of overactive bladder increases with age in men and in women, with the overall prevalence in this particular study being about the same, 16.9% in women, 16% in men. But note the prevalence reaching 30% in the older groups. The prevalence of OAB in women is perceived to be substantially higher than in men, but that's because so many of those studies were looking at incontinence. But this graph and the next will show you that when the definition of overactive bladder is used rather than incontinence, men suffer equally from overactive bladder as women, but they tend to be overactive bladder dry, while women tend to be overactive bladder wet. And notably missing from this slide and from all of our overactive bladder literature is the prevalence of overactive bladder in gender minorities. And this remains understudied and unknown at this time. When you look specifically at overactive bladder wet, the prevalence increases with age in men and in women, but it's higher in women than men at all ages. The prevalence of OAB with incontinence increases drastically in women after age 35 and in men after age 55. So now if you look at the prevalence of OAB dry, you see it also increases in men and women. And since the overall prevalence is similar between men and women, it's not surprising that overactive bladder dry is actually more prevalent in men. Given the high prevalence, it's worth mentioning impact, right? The impact of this condition on our patients. It's multidimensional with impact on psychological well-being, social interactions, occupational productivity, and intimacy, to name a few. And we see how common overactive bladder is in men and women, and taken together with this, the cumulative impact of this condition on society is quite high. So now let's take a few minutes and talk a lot about urgency, specifically this symptom that really defines overactive bladder. Overactive bladder is, as we mentioned before, a condition that must include this symptom of urgency. It is the sine qua non of overactive bladder. And our overactive bladder questionnaires do a really good job identifying the presence of urgency and the frequency of the occurrence of urgency in our patients, but it's difficult to measure the intensity of urgency. It's subjective. It's hard to gauge from person to person. Does that one have more urgency than that one? The occurrence of it, maybe you can gauge, but the actual experience of it is hard to. The way patients describe it is as a feeling that comes on suddenly, making you want to rush to the bathroom because you fear you may leak. And patients often use that phrase, they fear leakage, which used to be part of the old 1998 definition of urgency. Since urgency is the main component of overactive bladder and the term can be confusing to patients and to healthcare providers, the ICS revised the definition in 2002. Both of these definitions indicate that urgency is quite distinct from the normal urge to go, and the new definition eliminates pain, which really isn't part of urgency and is a symptom in and of itself. When you look at the spectrum of overactive bladder, urgency is right smack in the center. The larger clear circle represents overactive bladder, and within it you see a subset of urgency incontinence. You see the overlap with stress incontinence, which can result in either mixed symptoms or mixed incontinence. And appropriately missing from the diagram is the symptom of nocturia alone or frequency alone, because these symptoms do not meet the criteria for overactive bladder, which requires the presence of urgency. So why is urgency so bad? What does it do? Well, it drives frequency, sometimes from the urgency feeling itself, or sometimes preemptively from the fear that urgency may come on. It drives behavioral adaptations such as fluid restriction, toilet mapping, staying close to a toilet. It drives preemptive voiding or double voiding. It can restrict people's activities. It leads to wearing pads. And urgency precedes, and it possibly causes, the urgency incontinence. At night, it can result in nocturia and incontinence during sleep. To dive a little deeper into the physiologic manifestations, following the one arrow down, urinary urgency leads an individual to void more often at reduced bladder capacities with shorter intervals. This results in reduced volumes voided per micturition. So this means just more small pees all day long. Following the two arrow, urgency can wake you from sleep, or it can also result in urgency incontinence due to an inability to get to the toilet fast enough or to suppress that urgency. This figure is showing normal bladder filling physiology with the normal desire to void, or what we call urge, different than urgency, increasing with increasing bladder volumes. And in a healthy bladder, it's the reasonable deferment of normal urge wouldn't result in urgency or urge incontinence, unless you just took it too far. This figure represents the pathologic state seen with overactive bladder, with both a reduction in bladder volume and a loss of the ability to defer voiding. Because the bladder cannot comfortably fill to normal capacity, more frequent, smaller volume voids occur. And with the attempt to hold longer, urgency or urgency incontinence occurs. From a biochemical perspective, urgency can result from the bladder distension itself with stretch on the urothelium, the activation of sensory neurons, and the release of neurotransmitters. An identification of these pathophysiologic mechanisms, the neurotransmitters and their receptors, led to the pharmacologic therapeutics that Dr. Wien will be talking about, primarily antimuscarinics and beta-3 agonists. And neurotransmitters such as acetylcholine, nitrous oxide, and ATP are targets for pharmacologic agents to alter that perception of urgency. So while we've been focusing on urgency for its role in overactive bladder, it's worth mentioning that urgency can be part of the symptom complex for ICBPS. Patients primarily differ in the description of what drives urination. With OAB, it's the urgency itself, the fear of leakage or actual leakage. With ICBPS, it's generally the discomfort or pain with bladder filling or holding the bladder. And it's likely that there are two different afferent pathologies responsible for these conditions, but there may be some overlap as well. It's also worth mentioning that urgency in overactive bladder can be part of other symptom complexes involving pelvic organs as a result of pelvic organ crosstalk. This concept has to do with irritation or inflammation in one pelvic organ, evoking a hypersensitivity in the neighboring organ. And this may be due to convergence of afferent inputs at the level of the dorsal root ganglion or the spinal cord. So, what are the underlying pathophysiologic mechanisms responsible for the production of the symptom urgency? Involuntary bladder contractions, or DO. This is generally what comes to mind for most clinicians because we've been able to identify these on urodynamics in a subset of individuals with overactive bladder. But many individuals don't experience involuntary bladder contractions, but still feel urgency. The term for that in the old lexicon was sensory urgency. That has now been replaced with the term bladder hypersensitivity. Nonetheless, the pathophysiology can't be involuntary contractions alone. In fact, DO, as shown here on urodynamics, occurs in only about 50% of women with overactive bladder, depending on the population studied. In this situation, the bladder is objectively shown to contract spontaneously or with provocation, but the urodynamics don't explain the other 50% of the patients. And this has prompted further research into other mechanisms such as bladder afferent signaling, the central nervous system, to explain the pathogenesis of overactive bladder. So this leads us to this controversy. Is urgency muscle related? Is it a neural abnormality? Does it originate in the bladder? Or is it something else? OAB was historically thought to be caused by involuntary bladder contractions, which were either myogenic, the urgency was initiated from autonomous contractions within the bladder muscle itself, or neurogenic, the urgency was signaled from the central nervous system, which initiated then the detrusor contraction. But over time, additional separate and combined theories have evolved, and increasing evidence on the role of the urothelium and the suburothelium and bladder afferent signaling occurred in the early 2000s. Emphasizing an afferent urotheliogenic hypothesis, namely that urgency is initiated from the urothelium. It's felt that the disturbance in nerves, in smooth muscle, and urothelium can all cause overactive bladder. And this can happen with increased excitability of the detrusor muscle, increased permeability of ion channels. So if you think about all of these possibilities, someone else came up with an integrated hypothesis, which basically makes room for all these mechanisms to play a role in the multifactorial pathophysiology of overactive bladder. So let's dive into the neurogenic theory. This theory suggests that damage to the central inhibitory pathways in the brain or in the spinal cord lead to sensitization or from sensitization of peripheral afferents in the bladder. All these things can unmask primitive voiding reflexes that trigger the detrusor overactivity. And this can result from a damage in the brain itself, so an area of the brain that was providing this suprapontine inhibition. It could occur from damage to axonal pathways from the spinal cord, leading to the emergence of these reflexes, which could be triggered by C afferents coming in from the bladder itself. So essentially, increased excitability, connectivity of nerves provide this mechanism of communication between the muscle, the central nervous system, and the urothelium, leading to urgency. Pontine micturition center, or Barrington's nucleus, is vital to the coordination of voiding, and it can also be implicated in the pathogenesis of overactive bladder. Essentially, the cortical brain regions that regulate the pontine micturition center are the cingulate gyrus, insular cortex, prefrontal, and they're doing this through tonic inhibition, and with injury in those areas of the brain, that inhibition is no longer present. So to give you a visual on that, during normal filling, there's sensory afferent information coming in from the bladder. And then the red arrows are indicating the suprapontine inhibition that goes to the periaqueductal gray area, the pontine micturition center, that is inhibiting that voiding reflex from happening. The neurogenic theory implicates the loss of some of this suprapontine inhibition, which allows activation of the excitatory pathways, shown in green, stimulating the pontine-micturition center and eliciting excitatory neurotransmission in the micturition reflex. So during the storage phase, this manifests as urgency and urge incontinence. And the efferent output then makes its way down the spinal cord to the bladder, which can result in an involuntary bladder contraction. This figure is showing the inhibitory and excitatory neurotransmitters that act on the pontine-micturition center. With reduction in the inhibition, the excitatory efferent pathways are activated and lead to urgency. And this input to the pontine-micturition center can come from the cortex, as we described it. It can also come from spinal tract neurons or aberrant afferents coming in from the detrusor muscle itself. So now changing gears to the myogenic theory. So this theory puts the blame on the detrusor muscle itself, or the myocytes, for generating involuntary muscle contractions and that sensation of urgency. With this theory, the involuntary contractions driving it are primarily related to detrusor myocytes, allowing for increased excitability and electrical coupling between cells, as well as a hypersensitivity to the neurotransmitters and other stimuli. And then things like partial denervation, ischemia, inflammation, oxidative stress, and then the diuresis and metabolic effects of conditions like diabetes. These are all some of the underlying conditions affecting detrusor myocytes, which could be responsible for myogenic dysfunction. The increased excitability and electrical coupling of the myocytes allow the propagation of an electrical signal, and this creates the physiologic micromotions that then become synchronized into an involuntary detrusor contraction. You can see that these theories are not entirely mutually exclusive, so additional theories combining some neurogenic and myogenic concepts have been proposed. One theory proposes a leak of acetylcholine from parasympathetic nerves could create micromotions in the detrusor muscle. This could lead to afferent activation and efferent signaling. Another theory suggests the bladder smooth muscle has autonomous activity, but this may be modified by excessive excitatory or defective inhibitory inputs that could come peripherally or centrally. Now, the other theory here, the sensory afferent theory, arose after afferent nerves were identified in the suburothelial and space in the smooth muscle, and these afferent nerves respond to numerous stimulatory and inhibitory mediators, and neurotransmitters released from the urothelium interact with a variety of specialized receptors that will lead to signal transduction and wider neuroactivation. And this theory proposes that dysregulation of bladder afferent activity leads to aberrant micturition signaling with bladder efferent pathways, which is consequently causing that involuntary detrusor contraction. A growing body of evidence suggests that the urothelium is not passive. It's not just a barrier. It's responsive, and it's capable of detecting thermal, mechanical, chemical stimuli, and transmitters synthesized and released here alter the excitability of the afferent nerves, and that impacts detrusor contraction. Some of these neurotransmitters are compounds like acetylcholine, ATP, nitrous oxide, urothelial-derived inhibitory factor, and others. And this diagram is showing you how it works. The urothelium on top is in green, the interstitial cells in pink, and then the detrusor muscle fibers down below give you an idea how neurotransmitters released up in that urothelium can act locally in the interstitial cells to influence those neural fibers in the detrusor. So ion and cation channels in the urothelium mediate the response of the bladder to stimuli, and then the urothelial and suburothelial cells express muscarinic and purinergic receptors that activate sensory afferent communication to the central nervous system. The CNS communication then occurs starting at the bottom. Bladder afferents come into the spinal cord, travel to the periaqueductal gray area, and disturbances or defects could occur at multiple sites. The CNS control sensory nerves, motor nerves, and similarly, all of these areas are targets for drug delivery. This brings us full circle back to the brain, showing the integrated nature of several of these theories in the pathophysiology of overactive bladder. And it's likely many of these theories are correct, with different mechanisms being responsible for symptoms in different patients. fMRI has improved our understanding of areas of the brain identifying regions of interest involved in normal voiding and pathologic urgency. And this image is showing increased activation in the anterior cingulate cortex, matching urgency and continence severity shown on the heat map. These images come from my team at UPenn, where we identified several areas of the brain with increased activation in women with OAB. We then re-imaged the brain after sacral neuromodulation and found SNS attenuates the brain activity in at least 3 of these regions alongside their symptom control, and this further implicated these areas of the brain as being involved in overactive bladder. So a very smart guy who might be sitting right here at the table took in all of these theories and synthesized them into a few take-home points. No single set of data or hypotheses explain all occurrences of urgency. Several concepts seem potentially valid. OAB in a given individual may be due to only one or a combination of these mechanisms, and this concept may explain why some treatments are just more effective in some individuals than in others. Which leads us to our final section on pharmacologic principles. The pharmacologic targets match the pathophysiologic theories. Dr. Wien will expand on all the specific agents in these categories in the next talk, but the potential targets for pharmacologic treatment of OAB include all of these. And the reality is that some of these areas are easier to hit than others, and there may be overlap where some agents work via more than one mechanism, like blocking detrusor muscle contractility and also sensory afferent. The detrusor muscle and the neuromuscular junction have long been targets with the greatest drug development in that part, while potential targets in the nervous system or the urothelium are gaining more interest. So the ideal pharmacologic doesn't exist, but if it did, it would be uroselective. It would block urgency, block DO, have no effects on voiding, have minimal adverse effects, and no safety issues. And if we could develop a drug that only works on the bladder or the pathways to the bladder, we could avoid the side effects that have traditionally limited our pharmacotherapy of overactive bladder. Antimuscarinics were thought to work for OAB symptoms by binding the muscarinic receptor and preventing a bladder contraction, but accumulating evidence began to suggest that antimuscarinics were working on sensory afferent nerves as well. This opened up the possibility that they may be working in combination, and they may be dose-specific, and they may be formulation-specific. This figure is showing the decreased activity in 2 types of afferent nerves in the presence of an antimuscarinic. In the control group with the open circles on top in both A and B, you see an increase in nerve activity as the bladder is filling. That's what you would expect. The response is blunted in the presence of antimuscarinics, which is shown on the bottom in both A and B, supporting an afferent mechanism of action for antimuscarinics. Busy figure, but the combination, the combination of afferent and efferent nerves looks something like this, with the M3 receptors on the urothelium all the way to the left in the yellow area, the afferent nerves in the middle in the orange area, and the efferent nerves to the right in the orange area. And the lack of specificity of the muscarinic receptor is what also allows significant side effects with these drugs and has limited their acceptability now, especially since there are other options available, which brings us to the pharmacologic principles of beta-3s. Beta-3s, when activated, promote bladder smooth muscle relaxation, but they're also felt to inhibit afferent activation. 2 hypothesized mechanisms which beta-3 agonists could inhibit afferent activity include inhibiting the A delta fibers, suppressing microcontractions of the detrusor, and inhibiting C fibers, thus relaxing detrusor muscle activity and bladder tone. Novel pharmacologic targets are needed in an attempt to find uroselectivity, increase efficacy, decrease side effects. With the high prevalence of OAB and the impact of this condition on quality of life in the aging population, pharmaceutical companies are anxious to find new targets. And Dr. Wayne will bring us up to date on the status in drug development as well. So thank you for your attention.
Oral drugs is you, and then the advance is going to
So thank you. Good afternoon. My topic, oral single drug therapy for OAB. Ariana's going to talk about combination therapy, my potential conflicts of interest. These are some great sources. The first one is the guidelines that just came out last week, actually, in early view in the journal Urology. I compliment the committee because what they said was exactly what they felt, but on the basis of the data that were available. That's what the EAU had done for a long time. We didn't. That's now been corrected. So compliments to Eric, to Ariana, to everyone on the committee. So these are the potential management strategies of overactive bladder and detrusor overactivity. Most of what we're going to say this afternoon will concentrate on basically number one, decrease activation on the motor or sensory side of the micturition cycle. The others are possible. They're not really pharmacologic methodology. The ideal drug, as was mentioned, is going to block urgency, block detrusor overactivity when it's present, have no effect on voluntary voiding, have minimal adverse events, and also I left out be affordable. No drugs satisfy all the criteria. The treatment goals are important. So what's important to an individual patient? You know, I generally ask them, look, if I could fix one thing, what would it be? And the people that have urgency incontinence will invariably say urgency incontinence. The ones who don't will say, you know, this urgency, I'd like that to decrease, or I'd like to be able to get to the bathroom. But you have to remember the ultimate goal is management. It's not cure. You're not going to cure anyone, either with pharmacology or with any of the minimally invasive therapies. A reasonable goal is symptom improvement. You have to establish realistic expectations at the outset, and if you do, then you'll have less trouble satisfying the patients. The metrics that are used, the easiest one is urgency incontinence episodes. It's very difficult to measure urgency. A lot of patients don't understand what it is. Measuring urgency severity, which some studies have done, is even harder. You can measure frequency episodes. You can measure volume voided. Nocturia is usually not affected by the drugs that are used to treat overactive bladder, and you can measure quality of life. This is basically the new guideline, just the treatment angle down to maximal therapy, which would involve either augmentation cystoplasty or diversion or an indwelling catheter. And as you can see, it's sort of stepwise. However, one important statement that the guidelines committee made is step therapy really justified? No. So last year there was a nice editorial by Lenny Ackerman about step therapy. You know, it's not really warranted. And honestly, the truth is that you should use behavioral modification with every therapy that you use. So what is behavioral modification? Well, it includes all of these factors. It includes just voiding diaries themselves, fluid management, getting the pelvic floor to cooperate when the patient wants to suppress urgency by quick flicks of that. It includes biofeedback. It includes medication management. And basically, in both women and men, combining behavioral therapy with pharmacologic therapy produces a better result than either modality alone. So step therapy is really sort of silly and unwarranted. The additions from the two sets of guidelines, the EAU, European Association of Urology, and the AUA SUFU, EAU's at the top, reducing caffeine, reducing fluid intake, taking care of obesity. They concluded weak evidence for smoking. At the bottom, the additions from the AUA SUFU guidelines, smoking, correcting anxiety or depression, which will amplify symptoms in their relative relation to quality of life. Obstructive sleep apnea, you should always look for that. Fixing that will ameliorate the symptoms considerably. Managing diabetes, managing pelvic organ prolapse, taking care of constipation, taking care of obesity. All right, let's go down the drug classes. The antimuscarinics. The first important thing that was noted a while ago is, and I'll quote, "The available data do not support the conclusion that antimuscarinics at the doses we use in current clinical practice exert their action by inhibiting detrusor contractility. They act on the afferent limb of the micturition process. They suggest variables associated with sensation." So the antimuscarinics theoretically can act on the afferent, I guess the pointer doesn't show up, or the efferent phase of micturition. But in the usual doses, they do not affect emptying in patients with OAB. In higher doses, they can produce retention. In the overactive bladder patient in whom retention is not a goal, like non-neurogenic, they act during filling and storage and not emptying. They act on urgency. Urgency happens during filling and storage. It doesn't happen during emptying, right? So it's logical. This is Carl Eric Anderson's diagram that's never been improved upon. The effects on afferent activity go with dose, but the effects on voiding dysfunction itself occur only with a higher concentration of antimuscarinic, and you can see the therapeutic window for OAB is on the afferent side. This is a chart made up by the International Consultation on Incontinence. They make up a chart like this looking at levels of evidence that things work. A 1A recommendation means that it's been used in randomized clinical trials and shown to be effective. And you can see that all the antimuscarinic drugs and the ones with combined action means that in the laboratory they also have calcium inhibitory properties, get a 1A recommendation. The reported efficacy of antimuscarinics in clinical studies, I think you're familiar with these, and you'll notice that there's a very high placebo effect for each one of these. And you'll see the placebo effect manifested in all the given slides that I'm going to show, and quality of life always goes up. There's a high placebo effect for that as well. The reported adverse effects of antimuscarinics, I think all of you who have used these in practice are familiar with these: dry mouth, constipation, blurred vision. Side effects for cardiovascular problems are very rare in clinical practice. Incomplete emptying is rare unless you start with a large residual. It's possible to make it larger. This was the first major article published in JAMA Neurology about cognitive dysfunction occurring with increased anticholinergic load. And there are many articles in the literature now. This is a 46 study review that showed with increasing load of anticholinergics, in other words, antimuscarinics, plus all the other drugs the patient might be on that have anticholinergic properties, is definitely associated with a significant decline in cognitive ability. This is a consensus statement put out by the American Urogynecologic Society. It says basically the same thing. This is a white paper put out by SUFU on overactive bladder, anticholinergic medications, and dementia risk, and basically reports the same thing. So most of the articles report this. Supportive articles cite the total antimuscarinic load and long-term follow-up on studies that have used just overactive bladder agents, in other words, not on any other drugs with anticholinergic properties, is really limited. And it's also limited on drugs that either don't penetrate the blood-brain barrier very well, like trospium, quaternary amine, and also it's limited on drugs that get into the blood-brain barrier but then are pumped out by enzyme systems like darifenacin and also fesoterodine. So the recommendations for the EAU offer antimuscarinics for patients with urgency urinary incontinence. Consider the extended release formulations. If the treatment's ineffective, then either elevate the dose or add another agent. And notice the last statement: no anticholinergic drug is clearly superior to another for cure of or improvement of OAB, urgency urinary incontinence. Now, for years, the AUA guidelines resisted saying that, but they don't resist saying that anymore. And again, this is from the EAU. Just look at the top one. It says basically the same thing. There's not one that's better than the other. This is the AUA SUFU. I'm just going to read it. All of currently available agents demonstrated increased efficacy compared with placebo. Although the improvements are statistically significant, they are clinically modest. It is reasonable to assume that antimuscarinic medications are similarly effective without superiority among agents. So how do you compare one drug to another? Well, I've always felt that because companies choose the subjects to enter in their particular trials with great care, it's most useful just to take the information submitted to the FDA. In other words, the original studies, and let's compare the numbers there to see if really there is any difference. So these are the parameters the FDA utilized, and I'm going to use solifenacin and fesoterodine, not because I think they're the best, just because they're the most recently updated in their product inserts. And so just look at the circled numbers. Okay, drug versus placebo for incontinence episodes, because that's easy to measure. Okay, 2 trials with solifenacin 5 milligrams, with fesoterodine 4, with 3 trials with solifenacin 10, and 2 trials with fesoterodine 8. You can see that, well, yep, the results are okay, not terrific, and the placebo results are quite high. You can calculate a drug-placebo ratio, which I think levels the playing field for all drugs. And as you can see, they're all pretty much in the same range, except for one trial that seems to be out of kilter to another. But the improvement rate was only 61% in that trial, and that was just a result of the placebo being a little skewed. Now, the placebo effect is really important. This is an estimate on a series of studies gathered by looking at the placebo effects for urgency urinary incontinence. It's the same as it is for stress urinary incontinence drugs, duloxetine. Seems to be pretty constant. This is a bar graph. The darker ones are the drug effects, the lighter ones are the placebo effects. So it's pretty amazing. Now, some people have said, well, that placebo effects don't last very long. You know, I would dispute that for some drugs, because the long-term effects for patients that have had good success on antimuscarinics, let's say for 12 weeks, those people, when they're extended to 52 weeks, they have pretty much the same efficacy. And if the placebo effect was a part of their results at 12 weeks, it's going to be a part of their results at 52 weeks. I mean, if the placebo effect decreased, then the results at 52 weeks should decrease as well, and it doesn't. Is antimuscarinic therapy okay in the elderly? Both the European guidelines, the AUA guidelines say basically, yeah, the outcomes are pretty similar when stratified by age. Can you use antimuscarinics in men? Well, this is the EAU guidelines. They can significantly improve all the parameters in men. It's possible that they can be associated with retention, but generally only if the post-void residual is increased to begin with. Ariana will talk about combining these with an alpha blocker, but the overall recommendation is you can certainly use them in men that have an initially elevated post-void residual. You need to be a little careful. This is AUA SUFU, should offer patients with BPH and OAB monotherapy with antimuscarinic agents or beta-3 agonists, or combination therapy with an alpha blocker in either one of those, and have a discussion with the risk of basically retention. How about neurogenic patients? This is David Ginsburg's AUA guidelines on neurogenic disease. Clinicians may recommend antimuscarinics or beta-3 agonists or a combination to provide bladder storage parameters to be increased in neurogenic lower urinary tract dysfunction. Problem with antimuscarinics? Poor persistence. You can see these drugs, you can see what happens at 12 weeks. 12 weeks, the persistence is down to about 30%, 25%. Why is that? Efficacy, adverse events, cost, other issues. Usually you have a lower percent of discontinuations with extended release drugs, and in women for some reason. you have a higher reason for discontinuation or a higher percentage in younger people and also people that have unrealistic expectations. What about the beta-3s? This is about the mode of action in overactive bladder, originally published for mirabegron, but undoubtedly the same for vibegron as well. Relax the detrusor muscle directly, afferent inhibition, just like the antimuscarinics, and also they may decrease acetylcholine release from prejunctional receptors, which is a pathway for contraction on the central nervous system side. Again, if you look at the ICI recommendations for both of the beta-3 agonists, it's a 1A recommendation, mirabegron and vibegron. These are the EAU guidelines comments about the beta-3s. Mirabegron and vibegron are better than placebo and as effective as antimuscarinics. The adverse events with those drugs are similar to placebo. Patients inadequately treated with antimuscarinic like solifenacin may benefit more from the addition of a beta-3 agonist than from adding another dose of antimuscarinics. From the AUA and SUFU, the few studies that have directly compared antimuscarinic medications and beta-3 agonists demonstrated no OAB symptom control difference across arms. So the panel concluded that the efficacies of antimuscarinic medications and beta-3 agonists were similar. No guideline committee for the AUA in reference to this has ever said that, and I'm really happy that these folks, did. Beta agonists in men, same thing as antimuscarinics. You can certainly use them in treating overactive bladder symptoms. The risk of retention may be lower, actually, with the beta-3 agonist than with the antimuscarinics. Now, these are all studies where the companies selected the people to participate and also the exclusion criteria. What happens in real practice? Big article authored by Chris Chappell. So just look at the top, basically, the incontinence episodes per day and the percent decrease. You'll notice that they are lower than all the clinical trials, right? And I think that's what happens. I don't think that you're going to see the results that appear in the journals in your patient population unless you screen the patients very carefully to use the same criteria that the companies use. So you're not going to see the same results. Now, with mirabegron and also vibegron, I didn't have a picture of vibegron. The persistence is a little better, but it's not great. Okay, look at the percent. So maybe instead of 25 or 28%, it's 35 or 40% at 12 months. But that's not great, right? These are the adverse events with mirabegron from the package insert from the data that were handed to the FDA. And basically you can see that with hypertension, there's no difference between placebo and 50 milligrams, but there is between placebo and 25 milligrams. I think that's a statistical anomaly, but that's the reason that hypertension is mentioned in the PI for mirabegron and not for vibegron. In the elderly, the beta-3s are safe. Now, this is a strange statement from the EAU that was included in their guidelines about the elderly, just so you'll know that this is there. Solifenacin, darifenacin, fesoterodine, and trospium have been shown not to cause cognitive dysfunction in elderly people in short-term studies. Short-term studies, that means 12 weeks and not lifetime. So what about vibegron? This is the initial article about vibegron. So the drug placebo ratios and the percent reductions for urgency urinary incontinence, let's take that as a good marker. 59, 60%, but the placebo effect was 40%. Okay, that's high. Urgency, as you can see, none of the drugs are great with urgency. So here's one, 33.3 versus 24.7% in the placebo group. Voided volume, the drugs always come out better, but not that much better. 14.8, 1.35%. Vibegron is efficacious in patients it's efficacious in originally at 52 weeks. So is mirabegron. It's efficacious in the elderly, and it increases quality of life. These are the side effects, basically, and as you can see, with hypertension or increased blood pressure, there's basically not much of a difference between drug and placebo. Comparisons between mirabegron and vibegron, well, this one says vibegron is better. This one says there's no change, at least in women. If you look at the ratio changes in the drug-placebo ratios from what was handed into the FDA for approval, this is mirabegron in 3 studies, and this is vibegron. This is frequency, this is urgency incontinence episodes. You can see it's very close, slight edge to vibegron. This is volume voided, and the FDA allowed urgency to be included with vibegron. So, this is from the AUA and SUFU, and I'm going to read this because I don't want to misquote them. Meta-analyses demonstrate minor differences in efficacy, basically between the two. Vibegron further decreased the mean total of incontinence episodes by slightly less than 1, and marginally increased the mean voided volume per void by 10 to 20 mLs. Although statistically significant, the panel concluded that the clinical effects were so small as to presume each medication is equally effective. And then this one, beta-3s have fewer side effects. They have lower rates of dry mouth. They have less effect on post-void residuals. They have less concern, but still have potential concerns on cardiovascular function. The initial studies of mirabegron reported some mild increases in systolic pressure, but pooled analyses on mirabegron suggest no significant differences. The 2 currently available agonists contain different warnings about use. Mirabegron is not recommended for use in patients with severe uncontrolled hypertension, while vibegron does not have this warning. Heed the last statement. Overall, the side effect profiles are similar. We'll skip that one. What about phosphodiesterase inhibitors in men? Okay, this is from the EAU. Basically, use phosphodiesterase inhibitors in men with moderate to severe LUTs, either with or without erectile dysfunction. And there are many studies that are cited where the phosphodiesterase inhibitors work by themselves for lower urinary tract symptoms and also work with alpha blockers themselves. So this is from the ICI. Men, alpha blockers are considered effective for the treatment of both storage and voiding symptoms in men associated with or suggestive of BPH, not in men who don't have associated symptoms suggestive of BPH. Why do these decrease male lower urinary tract symptoms? Well, like many other things, we don't know. These are all the possibilities. I think the most likely thing is increased perfusion of the pelvis with increased oxygenation and basically decrease in oxidative stress. But any of these are possible. Estrogens, the Cochrane analysis in 2012, overall less frequency and urgency in women treated with local estrogen. Systemic administration resulted in worse incontinence than placebo. Vaginal estrogens may improve the symptoms of the genitourinary symptoms of menopause, so you should offer these in patients with lower urinary tract symptoms and associated symptoms. So the lessons learned, make sure in drug trials, if you compare things in the literature, make sure you're comparing apples to apples. The results are all over the board for efficacy, but the drug placebo ratios are really very close. Results in practice may not equal the results you see basically from the literature. For each drug, there seems to be a ceiling effect, and I'm not sure that ceiling effect for pharmacologic management will ever be exceeded. There's a substantial placebo effect. The efficacy results are moderate for both types of drugs. There's little difference within and between groups for antimuscarinics and beta-3 agonists. The beta-3s have fewer side effects and fewer cognitive issues. Thank you so much.
anyone needs like a, big stretch or stand up, turn around, feel free. All right. Okay, so now we're going to dive into combination therapy for overactive bladder. And this is specifically for overactive bladder, not all of LUTs, which is why we're not going to get into the combinations to treat like BPH or specifically voiding symptoms. This is really about the OAB part, the storage symptoms. So the only thing better than one drug is two. And at least in theory, we can potentially get complementary mechanisms of action with non-overlapping side effects. There are a variety of potential combinations for OAB. We're going to explore these that I have on the screen because we have some data for these combinations, okay? Antimuscarinic, antimuscarinic beta 3, alpha blocker, antimuscarinic, alpha blocker beta 3, and then PDE5 inhibitors and beta 3s. The rationale for combination therapy is to address the decrease in health-related quality of life that's seen over time with a condition like overactive bladder. The natural history is for the symptoms to progress, and additional treatment reduces symptoms and progression, and it needs to be balanced with the side effects of treatment. So combination therapy is only effective if the added efficacy of the second mechanism of action more than makes up for any additional side effects. It's important to think through the pharmacologic properties of the drugs you're combining to ensure the combination therapy makes sense and the side effects will be tolerable. Some of the earliest studies involved combination therapy with two different antimuscarinics. The most common antimuscarinic combo studied is solifenacin plus trospium. This made up 3 of the 4 published trials. As expected, a combo versus placebo would be more effective than the placebo, but also combo versus monotherapy showed statistically greater reductions in urgency and urgency incontinence than monotherapy. But clinical utilization of this approach is limited by side effects. So I'm really not going to talk anymore about this type of combo because in our aging population, we're really trying to get away from antimuscarinics, and it's not a long-term feasible solution for many patients at all. So this combination, however, is worth consideration, and reemergence of the concept of combo therapy came when beta 3s entered the market, primarily because of their different mechanisms of action and the relatively non-overlapping side effect profiles. So combo therapy with mirabegron and solifenacin is an attractive option without tolerability limitations that you would see with high-dose antimuscarinics. It was such a good idea that there were at least 6 combo therapy studies using mirabegron plus solifenacin published over a short 3 to 4 year period. And so you can infer from the sheer number of studies in a short period of time, there's great interest in seeing whether these combo therapies could produce greater efficacy with low side effect profiles. So in the Symphony study, patients who had overactive bladder symptoms greater or equal to 3 months, they had to have greater than 8 urinary frequency episodes in 24 hours, greater than or equal to 3 urgency episodes in 72 hours. Those patients were randomized using a factorial design. Multiple doses and multiple combos were tested. Solifenacin at the dose of 2.55 and 10 was utilized, and mirabegron 25 and 50, and then the various combinations listed. So this is a busy slide. It's showing clinical utility on the y-axis, and then various doses and combinations of mirabegron and solifenacin on the x-axis. And this analysis looked at benefit versus risk. And for the various doses and combos of mirabegron and solifenacin using MCDA, multi-criteria decision analysis. So first look at the green bars showing improved mean volume voided, improved micturition frequency, and improved urgency compared with low-dose combinations, monotherapy, or placebo as you move to the left. To get an assessment of the relative risk-benefit for combo therapy at the various different doses and different combinations, they used this decision-making tool that can take into account both the drug efficacy and the drug side effects. And all combination therapies achieved higher clinical utility scores than any of the monotherapies or than the placebo, suggesting an improved benefit to risk ratio or profile. The dose combination of solifenacin 5 and mirabegron 50 had the highest clinical utility scores, essentially created the greatest balance of efficacy and side effects. The BESIDE study is in patients who have persistent urgency incontinence after solifenacin alone. So participants in this study entered a double-blind randomization to either get solifenacin 5 plus mirabegron 25 with dose escalation later to mirabegron 50, or they continued on solifenacin 5 or solifenacin 10 alone. The primary outcome was mean number of incontinence episodes per 24 hours, and this was adjusted from baseline, with the greatest reduction seen in the combination mirabegron plus solifenacin treatment group in yellow all the way to the left. A secondary outcome, the mean number of micturitions per 24 hours, this is also adjusted from baseline, showed the greatest reduction in the combination group, again, yellow all the way to the left. Another secondary outcome, the number of incontinence episodes on the 3-day voiding diary. You can come up with a lot of outcomes if you keep, looking at all the data we record on people. These are absolute values here as opposed to reductions from baseline that the previous slide showed. So combination in yellow had the lowest mean number of incontinence episodes on 3-day diary. There was 4.25 compared to the baseline of 9.6. And this was statistically better than solifenacin 5, but it was not statistically better than solifenacin 10. When you look at health-related quality of life, you see clinically meaningful improvements from baseline in all treatment groups, but the combo of mirabegron plus solifenacin had a 3-point higher improvement in score compared to monotherapy. When you look at symptom bother, combo therapy in yellow, you see a greater reduction from baseline compared to monotherapy in green. And the patient perception of bladder health is on the right panel. And again, you see a greater reduction from baseline compared to monotherapy. Combination treatment is well tolerated. A 1 millimeter of mercury mean difference in systolic blood pressure was observed between combination solifenacin and mirabegron versus monotherapy with solifenacin alone. Dry mouth and constipation were as expected given the use of an antimuscarinic in all the treatment arms. So what about using tolterodine and Vibegron? What about this combo? And let's look at this versus Vibegron alone. So this study also used variable dosing. They used Vibegron 50 and Vibegron 100, which is not available in the US. We only have a 75 milligram option. And then several drug combinations were tested. For example, on the bottom of the tan panel, you have a rectangle. Of that rectangle, you have Vibegron 50 plus tolterodine 4 for 4 weeks, then Vibegron alone for an additional 4 weeks. So in this slide, the top panel labeled A is showing the reduction in daily numbers of voids from baseline. The orange rectangular bar on the bottom is the combination therapy with Vibegron 50 and tolterodine 4, and then the top in gray is placebo. So you can see, quite a bit of difference between combo therapy and placebo, and some improvement from monotherapy. Panel B is showing a reduction in urgency episodes. C and D are urgency incontinence and then total incontinence, respectively. So Vibegron is generally well tolerated in combination with tolterodine. More frequent reported drug adverse events were constipation, dry mouth, and headache. The incidence of constipation was higher with tolterodine monotherapy and tolterodine combo therapy than Vibegron alone, as you would expect. Similarly, dry mouth was higher when tolterodine was part of the regimen versus Vibegron alone. Headache, however, was most common in the Vibegron 100 and plus tolterodine group. So this data on combination therapy was used to support the AUA guideline you already saw today. In patients with OAB who do not achieve adequate improvement with a single OAB medication, clinicians may offer combo therapy with a medication from a different class. Combinations can come in other forms too, especially when treating overactive bladder in people with prostates. The diagnosis of BPH is significantly more common among men with LUTS than isolated OAB, 62% versus about 26%. Patients with a prostate who present with OAB predominant LUTS should be evaluated and assessed for the relative contribution of bladder outlet obstructive symptoms secondary to BPH, but often treatment of overactive bladder is possible. Based on history, men with LUTS are assessed for their constellation of symptoms. This drives selection of the first agent that would be prescribed. For men with voiding and storage symptoms, alpha blockers are often prescribed first, and if there's persistent storage symptoms, bladder-specific therapy is added. Alpha blockers alone, though, are known to improve both storage and emptying LUTS, with greater improvements in the voiding component in the middle bar graph. Antimuscarinics alone have also been shown to improve storage in men, decreasing urgency, incontinence, and frequency. And shown here are the improvements in OAB symptoms. Men and women were in this study. So placebo in green, tolterodine in blue, fesoterodine in pink. Significant improvements in OAB symptoms and urgency incontinence were seen with antimuscarinics in men, with retention rates as low as 1% to 2%. These rates are low because these are well-selected patients for clinical trials. The real-world experience can be different, especially when you have patients with mixed symptoms or patients who may not have met criteria for some of these clinical trials. So in the real world, when you have men with some amount of voiding LUTS, it's enticing to add an alpha blocker if you want to treat their bladder symptoms to try to prevent any exacerbation of their voiding LUTS. And so this trial, the Neptune trial, looked at combination of solifenacin and a formulation of tamsulosin and an oral tablet that had a predictable extended release and absorption. So men with storage and voiding LUTS with a total IPSS of 13 or more, maximum flow rates of 4 to 12, at least 2 urgency episodes per 24 hours, and 8 or more voids per day were randomized to placebo, tamsulosin alone, tamsulosin plus solifenacin 6 milligrams, or tamsulosin versus solifenacin 9 milligrams. You may wonder why they didn't just use the 5 and 10 that we have available, but that's how this was done. So what they found is that the 6 milligram solifenacin combo dose performed better than the 9 milligram dose in this population of men with moderate to severe storage symptoms and voiding symptoms. So this study showed a greater reduction in total urgency score versus tamsulosin alone, clinically relevant reduction in the total IPSS compared to tamsulosin alone, and positive results were also seen for several of the secondary endpoints: IPSS storage, quality of life, subscores, urgency, urgent continence, frequency, volume voided, and importantly, quality of life. So combination therapy is well tolerated. It did not show any safety concerns in this study. So this is a responder analysis with the top dark bars showing combo, the middle light blue showing tamsulosin alone, and that bottom gray bar showing placebo. Improvements in frequency, urgency frequency score, and patient global impression of improvement were all superior with combination therapy compared to tamsulosin alone. They extended the Neptune study to acquire longer-term data. They called this Neptune 2. The reductions in IPSS, the improvements in urgency frequency score during Neptune were maintained out to 52 weeks in this Neptune 2 study. Urinary retention occurred in 13 of 1,208 men for a rate of 1.1%, and catheterization was needed in 8 participants for a rate of 0.7%. In meta-analyses of 18 RCTs, for both storage symptoms and improving quality of life, antimuscarinics plus alpha blocker combo therapy was superior to monotherapy. Naturally, this combination would be tested next, right? Alpha blocker plus beta 3. So this study, the MATCH study, looked at mirabegron add-on therapy to tamsulosin and found superiority in the treatment of urinary frequency, OAB symptom score, IPSS score, and health-related quality of life. The yellow bars are showing results for mirabegron add-on therapy, while the gray is the placebo plus tamsulosin. And on top, you can see a reduction in the number of voids per 24 hours and an increase in mean volume voided on the upper right panel. And improvements in urgency and urgent incontinence didn't meet statistical significance in this study. This was another placebo-controlled RCT looking at mirabegron add-on therapy with dose escalation from 25 to 50 milligrams of mirabegron. Urinary frequency was improved in both groups, but statistically better in the combination group with an approximately 20% reduction. Effects were seen shortly after starting the medication, with continued improvements between 4 and 8 weeks. In this study, mean voided volume, urinary urgency episodes, mean total urgency frequency score were all statistically improved in the combo therapy group. In this study, the total IPSS on the bottom right was not different. So when looking at safety outcomes, there were more drug-related adverse events in combo groups, but we're talking about 6 versus 1 patient that experienced urinary retention. The change in PVR was about 10 to 11 milliliters, and there was an approximately 1.8 ml per second difference in Euroflow, or Qmax on Euroflow between groups. So studies like these led to the addition of the following guideline. You saw this already. Clinicians can offer monotherapy with an antimuscarinic or beta-3 or combo therapy with an alpha blocker and an antimuscarinic or beta-3 to patients with BPH and bothersome OAB. Combination has also been tested in men with, this combination has also been tested in men with persistent OAB. So this RCT, the CONTACT study, looked at tadalafil alone versus combo of tadalafil and mirabegron. So TG is the tadalafil, TMG is tadalafil plus mirabegron. The red bar in the center shows the change in OAB symptom score, and the graph on the right shows the improvements in symptoms from baseline to 4 and then to 12 weeks. So combination therapies are aiming to improve symptoms, often through non-overlapping mechanisms of action and non-overlapping side effect profiles to achieve greater symptom improvement with minimal increase in risk. And shared decision-making is key, taking into account the patient's specific comorbidities, symptoms, risk factors to really most optimally tailor treatment to patients. All right, thank you.
All right, so we're going to try to stay on time like the trains in Italy. We're going to try to stay on time. Let's see. Come on, slides. I'm going to take you a whirlwind tour through nocturia. It's going to be quick, if the slides open. Here we go. All right. So nocturia. Nocturia is actually the most prevalent lower urinary tract symptom. We haven't mentioned it yet till now, but it is the most prevalent lower urinary tract symptom. This is data from the EpiLut study from a number of years ago. But what's important is actually nocturia, once it gets up to 2, winds up being the most bothersome lower urinary tract symptom, and it is bothersome when it becomes greater than 2 or more. What is nocturia? The ICS determined, defined it as the complaint that you have to wake up 1 or more times to void. You have to actually go back to sleep and wake up. So if you go to the bathroom 4 times during the 11 o'clock news, that is not nocturia times 4. It is actually nocturia times 0. There are 3 broad categories of nocturia, or the causes, etiologic causation of nocturia. One is polyuria, making too much urine. That's day and night. One is bladder storage problems. You've heard a lot about that today, overactive bladder, BPH, etc. And then the third category is nocturnal polyuria, which is in and of itself a condition that we're going to spend most of the time talking about. Can't forget that patients with nocturia also have sleep disorders. So you have to ask the patient whether they're waking up to go to the bathroom or whether they're waking up because they're anxious about having to give a talk the next day at the AUA. All right, so what are the etiologic causes of nocturia? Well, polyuria is pretty easy. It's you drink too much or you have diabetes, insipidus or mellitus. Bladder storage problems you're very familiar with, OAB, BPH, etc. And then finally, nocturnal polyuria, which is actually a hormonal disease, which we will talk about shortly, but also can be related to medical disease or behavioral problems. It's important to remember that once you eliminate sleep disorders, the majority of people with nocturia have nocturnal polyuria. I'm going to say that again. the majority of people with nocturia have nocturnal polyuria. It doesn't matter whether you're in Europe, Japan, the United States. Those are 3 different studies. The majority of people with nocturia, bothersome nocturia, have nocturnal polyuria as a component of their nocturia. It may not be the only cause of their nocturia, but it's a part of their nocturia. How do you assess nocturia? You have to do a voiding diary. If you don't do a voiding diary, you can't diagnose the condition. That's my voiding diary that I use. It's a simple record of volume and time of each void, when they go to sleep and wake up, and the volume of fluid that they consume. Nocturnal urine volume, remember, does include the first void of the morning, but does not include the last void before bed. Once you have a diary, you can calculate something called a nocturnal polyuria index. That's a fancy way of saying taking the total amount of nocturnal volume, divide into that your total volume over 24 hours, and if it's greater than 33%, then they have nocturnal polyuria. That's the definition, and it makes sense. If you're 24 hours in a day and you sleep for 8 hours, 1/3 of your urine output should be, or I should say more than 1/3 of your output should not be at night, that 8 hours when you're sleeping. I wish I could sleep for 8 hours. Anyway, some diaries. This is a diary of a patient with overactive bladder. If you look, they have frequent small voids. So that patient doesn't have nocturnal polyuria. They just have overactive bladder. Treat the overactive bladder. Nocturia should get better. This patient has polydipsia. I can treat them all day with overactive bladder medications and DDAVP, but it's not going to fix the fact that they drink too much, even though they deny drinking too much, looking me straight in the eye. This patient has nocturnal polyuria. You can do the quick calculation from the time they go to bed to the time that they wake up versus the 3 voids they have during the day. They have a lot of urine output at night. That patient has nocturnal polyuria. And then there are patients who have combined disorders. This is one such patient who has not only nocturnal polyuria, 775 cc's at one void, 300 cc's, and then 290 cc's, but during the day, they also have overactive bladder, frequent small voids during the day. So the voiding diary is quite helpful. You could tell me that your patients aren't going to do diaries. I don't believe you. If you tell them the diary is important, they will do it. They only have to do 1 day of a diary, max 2 days of a diary. Multiple studies have shown that once you get past 2 days of a diary, patients aren't compliant, and it doesn't give you more additional information. So 1 or 2 days of a diary is all you need. So what are the etiologies of nocturnal polyuria that are behavioral? You're familiar with these patients who take diuretics at night, patients who drink a 6-pack of beer before going to bed, too much alcohol, too much caffeine in the evening, or excessive salt intake, eating a bag of potato chips before you go to bed also will create nocturnal polyuria from a behavioral perspective. Medical disease can also cause nocturnal polyuria. We'll talk a little bit more about this with atrial natriuretic peptide, but diseases like congestive heart failure, renal disease, venous stasis disease, nephrotic syndrome, hypoalbuminemia can all lead to excess fluids edema, which then gets third-spaced, and then when you lie down, it becomes urine at night. Of course, obstructive sleep apnea is an important cause. That is because of atrial natriuretic peptide release, which we'll talk about shortly. And then finally, there's hormonal causes of nocturnal polyuria. That is related to arginine vasopressin, which we'll talk about with respect to DDAVP. But as we age, the amount of AVP that is released from your posterior pituitary decreases. In the elderly, in some elderly, there's actually very little secretion of arginine vasopressin. And when there's no secretion of arginine vasopressin, which is primarily released at night, by the way, you make excessive urine at night because you're not reabsorbing your fluid due to a loss of AVP. Atrial natriuretic peptide is released from the right atrium in cardiac disease and pulmonary disease. Atrial natriuretic peptide causes a solute diuresis. If you have COPD, congestive heart failure, then you have excessive atrial natriuretic peptide, especially when you're sleeping or you have obstructive sleep apnea. That's the reason that those folks have nocturnal polyuria. Treat the underlying obstructive sleep apnea or the congestive heart failure or the COPD, and their nocturnal polyuria improves. How do you treat nocturnal polyuria for behavioral causes? It's pretty obvious. Restrict your fluids, change the time of your drugs, take afternoon naps or elevate your legs at night, compressive stockings, time diuretics, etc. How do you treat medical disease? I don't treat medical disease. I refer them out for their cardiac disease and their pulmonary disease. And then how do you treat it hormonally? Well, you have to understand what AVP does, arginine vasopressin. Again, it's released from the posterior pituitary. It's generally released pathologically because of changes in plasma oncotic pressure, excessive bleeding, etc. But it's also released at night. What does it cause? When you release AVP, which is a very, very short-acting molecule, it can have effects at V1 receptors and V2 receptors. We don't care about the response at the V1 receptors. It's the V2 receptors that are urologically important. When you stimulate a V2 receptor, which are located in the distal and collecting tubules of the kidney, it causes fusion of something called an aquaporin 2 vesicle, not particularly important unless you're currently a chief resident and about to take your boards. And that creates something called an aquaporin 2 water channel, which causes reabsorption of free water in the kidney. That's a lot of gobbledygook. I love cartoons. This is the best cartoon I've ever seen describing what I just told you. On the left is the normal glomerulus descending, ascending, and then collecting system. On the right, what you see is the effects of AVP, and what you see is AVP is causing the fusion of those aquaporin molecules in the collecting duct all the way on the right, and that causes creation of a very concentrated urine, but in fact causes reabsorption of free water into the fluid, into your interstitium, and that's what AVP does. So what's the clinical ramifications of AVP? As I told you, it decreased AVP levels in the elderly. It's a molecule that doesn't spend a lot of time in your plasma. It's metabolized very quickly. So there is a drug called DDAVP, which is a synthetic analog of AVP, arginine vasopressin, which is metabolized much slower than AVP, which has primarily effects at the V2 receptor, which is the receptor that we want to be an agonist for. It has very few effects at the V1 receptor. If you stimulate the V1 receptor, again, urologists don't care about that, but it does have some pressor effects. What does DDAVP do? Effectively, it increases urine osmolality and decreases urine volume. DDAVP has been given a grade A recommendation from the ICI. When you take the tablet, onset is in about 30 to 60 minutes. You should give lower dosing in females for genetic reasons that are beyond the subject matter here. The important thing is that DDAVP can result in hyponatremia. You're all familiar with that. That is tied strongly to age and gender and low baseline sodium. The important note is that that hyponatremia is not immediate in many patients. It can occur weeks to months later. So if you're going to initiate DDAVP therapy, you need to keep an eye on the patient's sodium, even if their initial sodium is okay after a week or two. How well does it work? This is a systemic review of almost 2,200 patients at 100 micrograms compared to placebo. It reduced about 3/4 of one void per night, but that doesn't sound very impressive, and it's not. But what it actually does is increase the time until your first void at night, which means you get more quality sleep, even though you're not reducing your voids so much at night. You are increasing the time until your first void, which physiologically gives you better quality of sleep and better quality of life, and that's why we give these drugs. What is the incidence of hyponatremia? In one meta-analysis, it was about 8%. Again, the risk factors: low sodium at baseline, older than 65, and if you're a female, and we talked about the monitoring plan. DDAVP is not a particularly safe drug. And this is, we kind of all know that. If you've prescribed it, there is a substantial incidence of hyponatremia. This is an interesting study from a couple of years ago, and what they did was they actually looked at the 4,000 plus patients from the NHANES trial, and they looked at just those who had nocturia 2 or more times. So these are not patients necessarily getting treated for nocturia. These are random patients, more than have 2 or more voids at night. And they just basically looked at their medical history, and with the presumption that these patients who have more than 2 voids at night would want to get treated for their nocturia, looked at all their medical comorbidities, and as you can see, more than 80% of them had some prescribing concerns with respect to DDAVP. That is to say, they had medical contraindications, they had drugs that could affect sodium levels. So the actual number of patients who are eligible for DDAVP is not 100%. It's somewhere south of 100%, and you have to be very cautious in prescribing DDAVP, especially to elderly patients. It is available currently as oral tablets. A couple of years ago when I gave this lecture, it was available in other formulations, including a nasal spray and oral disintegrating tablet. Neither of those are currently available on the U.S. market, to my knowledge. They were both taken off the United States market. I don't know whether they're available overseas. What about combination therapy for nocturia? I just droned on about nocturnal polyuria, but remember that there are other contributing factors such as OAB or BPH to some patients with nocturia. It's nocturnal polyuria plus something else. We did a study a number of years ago looking at a group of these patients. Where are we? We're here. And about 106 patients, we looked at females with nocturia and overactive bladder and randomized them to tolterodine or tolterodine plus DDAVP. The details are not particularly important, but what I really want to show you is that this is the results. The combination therapy is in blue for all of these slides, and the monotherapy is in orange. The orange is the tolterodine. And what you see is the combination therapy, monotherapy, look about the same. But if you split it out and you look at the patients who actually had nocturnal polyuria, which is this graph on the left, all the way on the left, there's a big difference between the combination therapy and the monotherapy. So in patients with overactive bladder as a contributing factor to their nocturia, combination therapy, as Dr. Smith had spoken earlier, is actually more efficacious than either alone. Future pharmacotherapies for nocturia, not very promising. There was a drug called fadovabagan. Don't know exactly what it is. It has been discontinued as of September 2021. It was a longer-acting V2 receptor agonist. I don't know why it was discontinued, but it was. There was an interesting drug combination of something called Paxerol. Alan had intimated the effects of NSAIDs and COX-2s on lower urinary tract dysfunction. You can actually combine Tylenol and an NSAID, and it looked like it actually improved nocturia to some degree, although it was not dose-dependent. That drug, to my knowledge, has not been marketed either. So for nocturia, again, a very, very brief and very fast tour through nocturia. It's a very common type of lower urinary tract symptoms. It may or may not be related to OAB. It is related to nocturnal polyuria in 3/4 of patients. There are 3 causes of nocturia. They're listed there. Diary is very important. Treatment is based on the underlying cause. DDAVP is the treatment for nocturia due to nocturnal polyuria. But remember that this is not a drug for everybody. Thank you. And then I'm going to open, let's see. Uh-oh. Oh, there we go. Okay.
So my job is to talk about the possibilities for future pharmacologic therapy for OAB. Again, potential conflict of interest. And I'll give you the summary, actually, before we do the talk. There's no shortage of theoretical mechanisms by which you could decrease the symptoms of overactive bladder, and there's no shortage of in vivo and in vitro models. The steps in drug development are daunting and they're very expensive. The results in small furry animals are often not duplicated in man. If you're going to develop a new drug, it has to be safe or safer and more effective than one already on the market, or it has to be safer and as effective and possess at least one, maybe theoretical advantage. There are a few, if any, viable candidates at the moment. So the potential management strategies, again, will basically concentrate on number one, the possible sites of action of drugs, basically anywhere in the central nervous system and anywhere down to the detrusor smooth muscle, or you can have a drug that acts on 2 or 3 or more of these sites as well. The main problems, number one, proving the drug is effective, proving it's safe, and ideally proving that it only acts on the lower urinary tract, a concept promoted initially by Dr. Carl Eric Anderson, my mentor. These are antimuscarinics and beta-3s that either are or have been in development. Are there any other possibilities for antimuscarinics? Well, the method of action dictates that they can inhibit only the bladder effects of acetylcholine, regardless of whether the release is from the nerves or the urothelium, and this fits in with the idea of a ceiling effect. Whatever antimuscarinic you're going to use, I'm not sure you're going to get a better result than the ones that we have. The problem with the central nervous system effects has already been mentioned, and that has to be heeded by any manufacturer that wants to get into this space. Are there other possibilities? Well, here are 3. You can no longer find this one in the literature, so I'm assuming that it's been discontinued. Here's an interesting idea. Suppress the dry mouth by combining it with something that actually stimulates salivary secretion. In 2013, there was a phase 3 trial in progress. Haven't heard about that. You know, I really condemn manufacturers that refuse to publish unsuccessful phase 3 results. I think that's a disservice to everyone. Here's another one. Can't find this either. It actually failed phase 2 study, so it's not around anymore either. There are drugs used in Europe that are not licensed yet in the US and may be. One is propivarine, which is kind of like oxybutynin. It's a mixed action drug. The calcium antagonist properties have been proven only in experimental animals. Here's some information about propivarine. The problem is, in order to get into the market, it's going to have to be at least as successful as the drugs on the market now in the United States. Here's another one, amatafenicin. Again, some studies showing pretty good results. The question is it going to be better or safer than the drugs now on the market? That's probably why it hasn't been brought into the United States, because no one feels as though it's worth the effort in terms of money. How about beta-3 agonists? You know, the real question is, how are you going to produce results that are better than the results you get with the 2 drugs that are on the market now? Salabegron was one beta-3 agonist. We've been awaiting phase 3 studies with a once-daily preparation for a long time. I assume that the development has been halted. Ritabegron was another one that looked great in the laboratory. It unfortunately failed the primary efficacy endpoint in phase 3 studies. There are a number of beta-3 agonists that are in the pipeline. There are 3 basic theories of mechanism that we've discussed. And the question is, what's going to make another beta-3 better than the 2 that are on the market? Phosphodiesterase inhibitors in men, in the US at least, only tadalafil is approved, but there's no reason why the other phosphodiesterase inhibitors shouldn't do the same thing, really. I showed this before, the possible mechanism of action on male lower urinary tract symptoms to account for the favorable results. Potassium channel openers, basically cardiovascular and heart side effects and very little clinical effect. It's a great theoretical mechanism. Calcium channel antagonists, you know, great theoretical construct. Knockout mice, you know, have markedly impaired bladder contractility. Clinical trials have produced no positive results. Prostaglandin receptor antagonists, again, promising animal models, but little success with clinical trials with a lot of side effects. These are basically the results in experimental animals, hasn't done so well in clinical trials. Surprisingly, duloxetine, which was a drug that was developed for stress urinary incontinence, when Bill Steers wrote his original article, he looked at that and decided to write an article about the effects in women with overactive bladder. Well, it actually was reasonably effective, but there were a lot of side effects. It's a serotonin norepinephrine reuptake inhibitor, and there were many discontinuations in the patients who took the drug versus the placebo. It may be that some other serotonin norepinephrine reuptake inhibitor will prove to be useful without the side effects that duloxetine had. Vitamin D antagonist, minimally positive clinical results. Neurokinin receptor antagonist, nice idea. So here's one story about one company that poured a lot of money into this. The neurokinin 1 receptors are a G protein coupled receptor found in the central and peripheral nervous system. Originally, it was used as an antidepressant and antiemetic in patients that were on chemotherapy. It does have experimental animal evidence of blocking detrusor overactivity. The original drug was a Repetant. It significantly improved OAB symptoms. If you look at the data, you would say that it moderately improved OAB symptoms. The problem was drug-drug interactions, and so basically that was substituted with another drug called Serlepitant because of this. Serlepitant was compared against tolterodine. Unfortunately, tolterodine, already on the market, was superior, and so basically development of this avenue of investigation was stopped. GABA is the chief inhibitory compound in the central nervous system, gamma-aminobutyric acid. So basically a modulator of that receptor. You would think that that would be receptive and would give you good results, and in fact in animals it did. The last comment that I saw, which was back in 2016, is that further studies of this agent would be of interest. Whenever you see that, I would not buy stock in that company. Okay, now this was supposed to be the savior. Basically, in the normal bladder, there's minor or any contribution to contraction by ATP. In disease, that changes, and maybe up to 50% of the contraction is due to ATP. So at least in pathologic activities, ATP seems to participate. So wow, why not get a receptor antagonist to ATP? ATP is released from the urothelium in response to bladder filling, like Ariana said. ATP receptors, or the PX3 receptor, a type of purinergic receptor, is expressed on bladder afferent terminals. Knockout mice show increased intercontraction intervals with no decrease in the pressure of emptying contractions. Wow, okay. So here's the drug, and this is the experimental evidence. The bottom shows an increased intercontraction interval. If you look at the right-hand side of the diagram, you see basically that total volume in the bladder animal, or in the animal bladder goes up, the frequency goes down, and the amplitude of an emptying contraction is unchanged. Okay, there it is, that's it. Well, here's a drug, alixapixant, that is a potent P2X3 antagonist. It's used in refractory chronic cough, which is thought to involve overactivity of that receptor. It's reasonably efficacious with good tolerability there. Unfortunately, in overactive bladder, it is not. So here are the numbers. They're pretty amazing. Reduction of urgency urinary incontinence of 55%. In the placebo group, 57%. Micturition frequency, reduction of 15%. In the placebo group, 19%. Urgency, 29% and 36%. Voided volume, 9% and 1%. That's the only one that really shows an effect. In nocturia, basically no difference. Wow, if the cannabinoids worked, then everybody would be on them, wouldn't it? So basically the site of action of these drugs really isn't determined. They can be in the brain, the spinal cord, or the periphery. Basically, there are multiple mechanisms by which they can reduce hypersensitivity of sensory afferents. One big study with MS, cannabinoids relevantly decreased incontinence episodes in all studies. How much did they decrease the incontinence episodes? 0.35 urgency incontinence episodes per day. Okay, well, yeah, statistically significant, but not terribly clinically significant. The TRP receptors, a family of receptors involved in nociception and mechanicosensory transduction in various organs. Well, in the bladder, wow, this looks pretty good. You know, it basically increases the intercontraction interval, that's the red bars. It doesn't decrease the magnitude of voiding contractions. It increases voided volume, that's the blue bars. You know, wow, I mean, this must be great. Well, there are different TRPM antagonists. This one was termed a successful failure. It produced hypothermia in animal models, and in human models it produced a perioral burning sensation. The TRPV1 antagonist in humans caused hyperthermia. So this is Francisco Cruz's statement at the end of a series of articles in the BJU International. There are reality that still need an enormous amount of work and dedication before becoming therapeutically useful, and that may take more time than we anticipate at the moment. I haven't seen much progress in this area in actually quite a long time. Opioid receptors. The mu receptor may modulate micturition. Tramadol is a weak mu receptor agonist. The active metabolites are stronger than the original drug. It was reported to have positive results in a proof of concept study. Unfortunately, this study was retracted due to statistical errors. So from the original article in 2006 until the retraction in 2014, everybody thought this was okay. After 2014, nobody thought it was okay. Here's another opioid ligand, and again, you can see that, wow, you know, this really does work in a guinea pig model. Now, whether this is going to work in humans, I don't know. You know, hopefully it will. Antifibrotic factors to decrease the formation of fibrosis in the bladder, which you would have to give either therapeutically after it's already established or prophylactically. It's another thought. Other ideas are up here. You know, none of these have produced any particularly relevant effects in humans when they've been tried. All of them do produce results in animal models. Basically, this is a great article if you want to read about current treatments and also possibilities of future treatments. It's in Pharmacological Reviews. It's by Martin Michel. You know, I would recommend it highly. This is the study that was spoken about first, using basically an injectable gene therapy. You inject it into the bladder and you basically open up potassium channels, which cause relaxation in an experimental animal. This was the original article. As you can see, you know, Eric participated in the theoretical constructs and some of the clinical trials. This was presented last year at the AUA. And so if you look at the clinical results, you'll see the clinical results are odd. I mean, most of the effects seem to be manifest with the injection therapy in the first 12 weeks, and then the results stay pretty constant. But if you look at the placebo arm for mean daily micturitions, you can see that it also decreased. If you look at the daily, urgency episodes, basically the second panel, you can see that the placebo also exhibits a significant effect, and that was stopped at 24 weeks. And then if you look at the third one, you can see that the effect of the drug is pretty much gone in 3 to 4 months. You know, I got this from someone who was the primary author on the articles, who said that the development of this has basically been stopped. So other possible approaches, you can combine drugs. You can combine drugs with other forms of treatment. You can use new variants of currently accepted principles. I don't think that's going to go anywhere in producing efficacy results better than what we have. How difficult is it to do and develop a new drug? Well, these are the stages that you have to go through. You've got to have a pharmacologic rationale. You got to have in vitro and in vivo models. You have to do toxicity studies. And then you need to do phase 1, phase 2, and phase 3 studies. This is a nice article that looked at the probability of success all told in phase 1 articles, or 6.3% of those that progress to phase 2, 31% of those that progress to phase 3, 58%. So overall success, 9.6%. If you looked at the time period 2011 to 2014, a probability of maybe 12% of success. In our field, it's a little better than it is in oncology, but as you can see, phase 1, 29 or 21, progressing to phase 2, 27, progressing to phase 3, 64, and when you get to the FDA, even though you've gotten through these things, only 80% of the drugs are approved. Developing a drug probably costs a minimum of several $100 million. So, in summary, no shortage of theoretical mechanisms, no shortage of models. The steps in drug making are daunting and very expensive. Small furry animals don't necessarily duplicate the results in man. A new drug has got to be as safe or safer and more effective than one already on the market, or it has to be safer and at least as effective and possess at least one, maybe theoretical advantage, and there are a few viable candidates at the moment. Thank you so much for your attention.
We have time for a couple of questions, if anybody has any burning questions. Otherwise, as faculty, we'll stay around for a few minutes. Yes. Hey, Art.
How concerned should we really be about this dementia risk with anticholinergics? I mean, we give, about every 100 people that we give an anticholinergic to, how many are we thinking we're inducing early dementia? One or two? That's the significance. We just got to talk about it, or is it like 20, 30, and we should talk about should we really be using this class medication?
I'll make a comment, but I'll defer to Alan. My comment is the SUFU white paper suggested that if you're going to put a patient on a drug for more than 3 months, there's an increased risk. I'm not sure they quantitated that risk. What that makes me do is counsel my patient that that is a risk. Whether or not the drug works for them is almost secondary. Are they willing to take that risk? And I can't quantify it for them. Alan, do you want to add anything else?
Well, originally I'm from Philadelphia, so I'm very risk averse. I think it's a good argument for using beta-3s rather than antimuscarinics, especially since, you see in the guidelines, there's really not much difference in efficacy. Now, the issue is that if you took the individual drugs by themselves and you looked at people in whom only that drug was prescribed, or you looked at people in whom only that drug was added to whatever they've already been on, nobody's done that study. As you can imagine, it'd be a very difficult study to do. So my go-to antimuscarinic in the U.S., very honestly, is trospium. It's available generically, and that's what I use because in healthy people, it doesn't get through the blood-brain barrier. Now, in diseased people, does it? I don't know the answer, but I think theoretically it's better, especially in older people. Now, it does have the same side effects as, the other ones do. It's got dry mouth, it's got constipation, blah, blah, blah. But I think it's a theoretical rationale for using the beta-3s. I mean, what do you think, Ariana?
I think the only reason we don't use beta-3s in everyone is the difficulty with insurance companies. And I think if you can implement a system in your office to facilitate the prior approval process, to have somebody dedicated to doing that, you probably would choose to use those drugs more often. There's also cost concerns, so I don't want to say it's only the prior approval process. The cost is higher for sure. I would say, especially with the amount of literature that has accumulated over the last few years and the changes in guidelines, I talk about it with every patient that I give an antimuscarinic to. I think it's 2025.
Yep.
Not sure that will decrease the price. We'll get one more question.
Yeah, usually the combo effects
I think that's fair. I think those studies haven't been done, but I think that's a fair statement because the primary literature suggests that those antimuscarinics are not different.
Yeah, I think that, I think the AUA SUFU guidelines are really good because they come out with actual statements. They don't pussyfoot, around the fact. They don't give you a diagram and say, here, you figure out which drug is better. They just say, look, they're all the same. And there's not a lot of difference, if any, between the beta-3s and the antimuscarinics as far as the efficacy is concerned. So, congratulate, these two are both on the panel, so my hat's off to them.
I want to thank everybody for staying through the end of the course. Really appreciate it. Enjoy the rest of the meeting. Thank you.